So today, I just want to be clear. I've been working on this project for the better part of a year now, but it is still very much a work in progress. So I'm hoping that you can help me continue thinking in this space. One of the things that I have figured out in the time that I have spent on this is that this is a place and a space where I really need to read, but especially listen closely and carefully, because many, if not most, of the most important perspectives are not written in this space. Most of the folks who are impacted by what I'm looking at don't write because they're too busy and they're too tired. They also frequently are parts of communities that don't value writing as the thing to make the world better. We are in a different space in that way, but as a result, there isn't a lot necessarily written in this space. And so again, I'm looking forward to the end of this where I can listen to you and hear your thoughts on what I'm talking about. But just to get a little, get us centered this morning, or afternoon, now that it's still morning. We're looking at substitute decision making. And so just to be clear that folks understand what I'm talking about here, I'm looking at it particularly with healthcare decisions. And what this looks like is a patient who's not able to maybe understand the condition that he, she, or they have, and the treatment options available, or this patient is not able to evaluate those options based on that person's values or goals, or that person is not able to choose the best option of those options, or that person is not able to communicate that choice. In that situation, so these are frequently understood as the elements of what it means to have decision-making capacity in the healthcare context. If any one of these four elements fails, someone does not have decision-making capacity. And in that context, that's when our healthcare providers generally look for someone else, most often a close family member, to be able to be a part of the informed consent or shared decision-making process for that particular person. And so that's when you see the acronym SDM today, that's what we're talking about. We're talking about this space, the decisions made in this space for folks not able to make them for themselves. And so the person who does this, so let me give you just a quick example. Where might this pop up? How does this happen? So it can be from brain injury, whether it's traumatic or acquired, like a stroke. It could be a mental health problem like dementia. It could be a learning, developmental, or other cognitive disability that alters people's abilities or affects people's abilities to do one of those four things. It could be because they're being treated for something and the medication or the surgery, they're unconscious. In that time and in that space, someone lacks decision-making capacity for themselves, or they may have substance or alcohol misuse. And so that may affect someone's ability to make decisions in a healthcare context. So to get a sense of how frequent this is, if anybody can find data, here's my first call. If anybody can find data on how many people at any given time are not able to make decisions for themselves in the healthcare context, I would love to see it. The best I was able to find are proxies. So to give you a general sense of how many people this may be affecting at any given time. If we look at dementia, we have nearly 6 million people in the United States and at least 500,000 people in Canada currently living with dementia. We have, if we're looking at stroke or other brain injury, it's the second most prevalent disability in the US. So it's about 13.5 million Americans and 1.5 million Canadians. If we're looking at alcohol or substance use, it's an estimated 3% of Canada, estimated 5% of the US, or if we're looking at folks close to death. That was the one other proxy that I found. Roughly 2.8 million Americans are dying each year, and roughly 287,000 Canadians are dying each year. Now let me just be abundantly clear. Not all of these people require a substitute decision maker. Many of these people still maintain their decision-making capacity. But for many, if not most of them, at some point in time along the course of their illness, there will be a period of time when they are not able to make decisions for themselves in the healthcare context. So I don't pretend that this is how many people need it at any given time. I can't find that number. Again, if you know where I can find it, I would love a direction to that. How do people become the substitute decision maker then? There are 4 different ways that this might happen that I've been able to identify. The first one, probably the most familiar one, is an advance directive. A patient, while they have decision-making capacity, fills out the requisite form, talks to the right person, is able to go through the procedure to officially say, that's the person that I want. I mean, right now, I can point at the person that I want. He's right there. That's my husband. But we've officially filled out forms so that he would be recognized at that person in the event that I lose capacity. Fun fact, he did not necessarily have to consent to that. So just because I fill out the form doesn't mean that he necessarily had a say in me naming him as that. So many people are surprised to find out that they are someone's substitute decision maker. Not good practice. He and I have lots of conversations. Same thing with my sister, who's my secondary substitute decision maker. If I don't do that, if an individual patient doesn't do this, doesn't go through this process, the next step could be that a family member or a hospital or a nursing home goes to court to get a substitute decision maker named. And so the family could go and say, I would like to be this person. Or the hospital or the nursing home could go to a court or a tribunal. Now, my understanding in Ontario in particular, it's not a court, it's the Consent and Capacity Board. And so I'm using court and board broadly here, so different states, critically important to understand about this. How this works is state-specific in the US and province-specific in Canada. And so trying to come up with a generalized norm, just recognize there's a tremendous amount of variability, but some broad similarities across all of the processes. And so once you have someone who's court-appointed, that person becomes the legally recognized substitute decision maker. In the event that someone doesn't go to court to do that, then in many, if not most jurisdictions, there's a statutory default. There is some statute that gives a list. It might say in this order of priority, frequently starting with spouse, and then potentially going to adult children, and then potentially going to parents of adult children, and then possibly to grandparents. It might include broadkin. One of the challenges and interesting bits in this place and space is not all of these statutes have been updated to recognize families that are not married, families by blood, families by legal recognition in terms of adoption. And so some of these statutes may be a problem. Lastly, you might just have the institutional policy. So if you can't find this person, or these people all say no when asked, then most institutions have the, and who do we go to next? And so it could be a part of any of these things that allows someone to become, or requires someone to become, a substitute decision maker. When folks land in this role for this reason, what I'm most interested at this point is how do we evaluate whether they're making good or bad decisions? The current system that we have is we first expect the substitute decision makers to be guided by any patient instructions that they've received in the past while this person had capacity. So these are frequently known as advance directives. They may or may not always be formalized. But here, this could be a living will. This could be the appointment of a decision maker. And as soon as they say, yes, I would like my sister to be the person making decisions, whether or not they provide any more instruction is truly up to the individual. Fun fact, if I've got my data right. So 93% in Canada believe it's important to discuss their advanced care planning with friends and family. But only 17% of people in Canada have advanced care plans. So there's a huge discrepancy of how many people have this, despite how many people think it's important. So right now, only about 17% of Canada has this. So this doesn't frequently guide decisions. When it does, especially under the legislation that I've read in Ontario, what is said in those documents is binding on the substitute decision maker, so long as it anticipated the circumstance and the situation in which the person finds themselves. But for the other 83% we then try, as best as we can, to have the substituted decision maker step into the shoes of the patient. Tries to pretend that they're just that patient's voice. And they try to step into the shoes of the patient, where the patient is, and make the decision that the patient would make if he, she, or they had the opportunity and the ability to make it at that moment. So we call this often substitute decision making, or a substituted judgment for the patient. But sometimes, often, substitute decision makers haven't had the conversations needed to know what a patient would want to do in that circumstance. And so that's where we then turn to, and most of our statutes explicitly incorporate this fiduciary standard, this best interests standard of, let's take a look at what we collectively, or reasonably, or medically think is in the best interests of this particular person. So that's where we currently are. So where's their problem? I think for many of us, how many of us would like to be the center of decisions made around us? I know I would. I like being the center of things more often than not. But I also know that when I make decisions, I'm not just thinking about me. So when somebody's supposed to step into my shoes, I want them to think about the people who are important to me as well. And so here, I would want my husband, Scott, to think about the impact of the decision on him, because I care about him. But in that circumstance, if he articulated, I can't handle this, I have heard numerous professionals frame that as a conflict of interest, that he is a conflicted individual and potentially acting unethically because he's thinking about him. So, more specifically, many of our substitute decision makers are not just substitute decision makers. Were they just that? And most of our professionals are. They're making a decision for a patient. They're making a decision for a client. We have structured our medical system, our legal system, our nursing system, our social services in a way that professionals are protected and trained on how to make decisions for others, putting the person, the client, the patient first. We get our best interests language from that fiduciary understanding. But many, if not most, of our substitute decision makers are not professionals. In fact, we're increasingly asking non-professionals to be making these decisions as opposed to the professional, to deliberately inform the professional decision. We're asking for these non-professional opinions and this non-professional expertise, but our current language, from my perspective, doesn't seem to incorporate, doesn't seem to acknowledge this. So, more specifically, this legal and ethical framework was written primarily by professionals, as it should. There's nothing wrong about that. Let me be clear about that. There's nothing wrong about professionals writing this stuff. That's our job. And we're doing a lot of this day to day. But we are differently situated from many of the people who are making these decisions. And we focused primarily on the most contentious ones, the ones primarily at the end of life. Medical technology, things that happen in hospitals, things that happen in nursing homes. A relatively short period of time. But the number of substitute decision makers working with caring for chronic diseases incorporates and anticipates a very different time span. I think many, if not most of us, are able and willing to sacrifice ourselves, to dedicate or to put our lives on hold for someone else if we're talking days or weeks. But when we start talking about months or years, the ability, the wisdom of doing that, of completely putting ourselves to the side, starts to become more practically problematic. It takes a different emotional toll. It takes a different financial toll. It takes a different physical toll. It takes a different spiritual toll. Between life or death, when we frame it that way, as most of these standards were framed at the time that they were created, versus good day versus bad day, doing better or doing worse, is a very different framework of what might factor in and how important that decision is compared to life or death decisions. So some of that original framing seems potentially problematic to the extent that we use these standards to evaluate anything other than a true end-of-life decision. As a result, our forms and our standards don't actively seek a patient's interest in others. So we ask, do you want cardiopulmonary resuscitation? We ask, do you want ventilation? Do you want to use a ventilator? We ask, do you want to use antibiotics? We ask, do you want artificial hydration and nutrition? We don't ask, who else do you care about? Who do you care? Who else should we be thinking about when we're making decisions? We don't ask that. And it could be that the answer for many patients is like, no, don't think about anyone else. But when most of us have capacity and loving relationships, or even non-loving, challenging, messy, sloppy family relationships, we still think about those people and factor them in. I feel like we've lost that with our current standards when the professionals who have no insight on those relationships are the ones making the decision. Additionally, and I think critically important, is the informal care that is frequently assumed in a number of these decisions. So these are the folks who are driving. These are the folks who are doing grocery shopping. These are the folks who are making meals or coordinating meals. These are the folks who are cleaning the house. These are the folks who are doing laundry. These are the folks who are doing bathing, who are toileting, who are cleaning. One of the estimates that I recently saw was that between 75 and 80% of care for cancer patients is provided by informal caregivers. A vast majority of the care. So when we think of the decisions, it's one thing if we're making a decision that's exclusively implicating hospital resources or nursing home resources. But as soon as we're making a decision where there's going to be an assumption, where there's a gap in the professional care, this substitute decision maker is inherently, profoundly impacted in terms of time and often in terms of finances. Given that expectation, we have not met that expectation of informal care with any training or with really any support or any real recognized standards of care. And so think about it. How many folks in here either aspire to be or are a legal or medical or nursing or social work professional? So there are a whole lot of folks in here. We've had a lot of training. We've been taught what our standard of care is. So in the US, lawyers need to be candid to the court. We need to be competent. We need to maintain our clients' confidentiality. We need to communicate with our clients. We need to be diligent. Those are our we know that that has been agreed upon, that is what it means to be a good lawyer. With physicians, the standard of care is obviously varied in part by practice and setting and things along that, same with nursing, but there are agreed upon standards of care. And you cannot be legally held accountable for something above and beyond that. Of course, ethically and socially, sure, there may be higher expectations, and I kind of hope there are higher expectations than our stated goals and our stated standards. But for informal care providers, they don't have that. They don't know necessarily how clean is clean. How much nutrition? What food is best? Do I really need to be home? Do I need to get them more contact with other people? We don't know. We do our best, but we don't have clear standards in the same way that protect someone if when they've done something that other people are judging harshly. Also, the accountability component tends to be social. It's relational, it isn't legal. Right? So these folks get excommunicated from families. They lose the informal support around them. So it's a different kind of accountability. And if there isn't a standard for all, it's going to be incredibly subjective. And that may be as it should be. But when we have a decision-making standard that doesn't take that into consideration, that seems potentially problematic. So we instead default to the fiduciary standard. We default to this best interests standard, this professional standard, and this language of conflicts of interest. And their care is unpaid. It's unrecognized. It is unsupported, often by employment policies, often by community programs of where is their money? Who may be paid for this informal care? Very different from most professionals. Additionally, these folks have less, I would argue, less choice as to whether or not they're going to become a substitute decision maker. And they have less control over the circumstances under which they will become one, unlike professionals, where we can pick the practice setting. We can pick the client or patient population we care to engage with. And we can set hours. And we can go home at the end of the day or at the end of the week. And the amount of out-of-pocket expenses to us, beyond business expenses that we frequently get paid for, or at least can budget, our informal care providers do not have the same privilege, the same protection in that space. And so I argue that projecting this privilege, this professional privilege, on folks who do not have the same training, the same support, the same control, the same limitations in time, is going to only perpetuate existing inequities and injustices. So to give you some data on this that I think supports this, and again, here's the thing, still a work in progress, merely an argument, please push back. One of the things, I grew up on Snoopy, so I love peanuts. Here, I think of Linus as the informal caregiver. I think of Lucy as the professional. For professionals who adhere to our ethical principles, our brains are wired in a way to let us feel that we are good people because we are ethical people. And when we project a standard that assumes and has incorporated the systems in which we practice our professions, and someone else isn't able to live up to that, they're bad, unethical, and selfish. So it could be either fundamental attribution bias, it could be actor-observer bias. Our brains do this unless we actively watch ourselves do it and then undo it. But this is where we assume that we are good, and our goodness has to do with our fundamental internal characteristics. And if other people are good, we frequently say it's because of the circumstance and situation they're in, not necessarily them. Alternatively, we say, if we do something bad, it's the system we're in, we're still good people. We did the bad thing because of the circumstances we're in, but we don't give other people that latitude. We don't give them that benefit of the doubt. We don't give, often because we can't see their system. We can't see the circumstances necessarily that people are navigating at a particular time. So when you have a professional group of folk who are human and wired this way, who also have a power dynamic and an ability to gatekeep to services, an ability to say, yes, this person is worthy of these services or not. Yes, you are worth this referral or not. Yes, I will work. That gatekeeping process, as soon as you start seeing the person you are meant to serve as someone who's maybe not good, not ethical, or potentially selfish, we start to work less hard often for those folks. And so the additional resources that may even be available for these informal caregivers may not be accessed nearly as much. Add to that, again, sort of a sense of who are these folks, how prevalent is this? So it's 25% of Canadians currently are identified as carers. Now again, not all of these folks are necessarily substitute decision makers, except for every decision they make that affects the person they're caring for. What's for dinner? What laundry detergent? What clothes? Where are you living? Right? So there are still some decisions, even if it's not officially or formally in a healthcare context, we all make decisions for other people all the time. And I don't think any of us could always live up to a best interest standard for every decision we make for someone else. But we have 50% of carers in their peak earning years. To the extent that folks are experiencing a need to trade off time or trade off money, this has significant implications for their ability to retire and the resources available when they're no longer able to work. Most of this community care, again, 70 to 80%, is informal care, not paid care. 6.1 million of those carers are actively juggling work and caregiving. Many who are not doing that gave up work to be caregivers because the work that they do would not necessarily accommodate it. It is disproportionately, but not overwhelmingly, women in Canada. In the US, especially if you factor in the paid informal care force, so the folks providing home care, it is overwhelmingly women. But even that changes by age. It's also very different by community. But I think lastly, and a critically component one, $12.6 million a year is actually being paid by these informal caregivers. So not only not being paid, they are paying. The estimate is $25 billion of unpaid labor to our healthcare system. It's really easy to make decisions that are best when you're dealing with the minority amount of the service, a minority part of the care. You're getting paid for it. You're trained on how to make those decisions. None of that applies to our informal caregivers. Add to that, for those who are paying, this is a 2020 study in the US for AARP, or American Association for Retired Persons. So in terms of the parents or the adults who are providing financial support either to their parents or their adult children, over half of them are finding it to be a high financial strain. So again, these are folks most often in their peak earning years who are really struggling. And it's not all, but it is a majority that are encountering a significant burden because of the caregiving, because of the support. And not all communities are affected similarly. So when it comes, this is from 20 years ago, so this is outdated in terms of that, but I think it was a lovely graphic, so I thank them for that. The update is that, the updated data on that, in the US anyway, is that Hispanics, so non-white, non-African American caregivers, have the highest reported prevalence of caregiving at 21%. So significantly less than the 34 here, but still greater than any other identified ethnic group in the US. African American families, 20.3% of African Americans identify as caregivers. 19.7% identify as Asian. So this has evened out a bit in the last 20 years. But the number of white folk who identify as caregivers has actually gone down from 19 to 16%. And so to the extent that other injustices, other burdens, other disproportionate impact falls, again, here I have to speak primarily from a US perspective, which I know is quite different from a Canadian's perspective in this space. But our communities of color take on far more burden generally. This is adding to that. Or it's a part of it, that injustice between white folk and folks who are not identified, who don't identify as white. It also, the burden of care also differs, at least again in the United States, differently from ethnic group, between ethnic group and races. So African American caregivers are much more likely to provide help with more than 3 activities of daily living as compared to white caregivers or Asian Americans. So the care burden, the number of things that need to be done, is still falling more on our Black communities than our white and our Asian communities. Add to that the gender imbalance that we saw a little bit of. Depending on which it is you look at, this burden seems to be falling significantly more on women than men. Fun exception, at least I think it's an interesting exception, it's not that different between men and women in the LGBT community. And so many of the men who identify as gay are taking on that primary caregiving role and doing as much care as the average female caregiver in other contexts. And so to the extent that we have existing biases, prejudices, inequalities, or injustices, much of the burden of this informal care seems to be falling in line with those existing ones. So, I was trying to ask 2 questions. The first one is, should substitute decision makers ever factor in their own interests when making healthcare decisions for others? If you are similar to me and accept the advice of the airplane safety message that people should put their own oxygen mask on before trying to assist others with theirs, I think the answer to this first question is yes, but the answer to the second question of how is infinitely messier. So even if we come to a consensus on the first, which we may not, that does not, I think, inherently lead to one clear path forward. But I've had some opportunity to think about what this might look like. So we've been operating primarily in a system that has prioritized and really put at this, and it's been centered on patient autonomy. It's written into a number of statutes. It's everywhere in clinical ethics textbooks, this concept of patient autonomy. So one broad path we could do is improve that. We can find ways to improve that. I'll talk about a couple of those options in just a moment. The other option is to then actually just recognize interdependency. For the legal and medically minded folks in here, let me give a huge shout out to the nursing and social work folks. They've already figured this part out in their codes of ethics. They identify that a patient can be a family. And then all of the other patient-nurse relationship or patient-social worker relationship continues. But they recognize that patients may not always be individuals unattached to anyone else. Law and medicine has not done this yet. So we've got 2 options. How heavy a lift each one is differs tremendously. I have a hunch that generally speaking, this is a heavier lift, except in nursing and social work. This may be what more people are interested and able to handle at the moment. So in terms of some of the options here, we could improve the support for informal caregiving, for mental health, for long-term care, and home care. This would both improve, it would start to put informal caregivers more at parity with professionals. It would also provide more of the community resources that caregivers often need, whether it's for respite purposes, whether it's their own mental health. We could do that. Obviously, it's a very resource-intensive option. We could educate professionals and revise forms. to include relational priorities of the patient. And then also in that, make explicit the current implicit assumptions of informal caregiving. So in our conversation about artificial hydration and nutrition, we could talk about what that means for lifespan. We can also talk about the fact for a lot of folks, artificial nutrition and hydration means they get to go home. But it usually requires someone continuing that artificial nutrition and hydration and making sure that it doesn't get infected. And again, 70 to 80% of the time, that's an informal caregiver. It's part of potentially making these implicit assumptions. The people who clean wounds, the people who change dressings, the people who are responsible for cleaning and maintaining the ventilator if somebody goes home with the vent. It's rare, it does happen. The conversation in the context of ventilators tends to be much more robust than folks going home with artificial hydration and nutrition. But also how much longer somebody will need transportation, how much longer someone will need 24 hours of somebody in the same house, how much longer will we could potentially make that more explicit. And in doing this, we would have patients thinking about that more explicitly when they fill out their advance directives. So if our advance directives could do that, they could identify the other people they care about, and they could be more explicit about what kind of care, informal care or burden, they are okay with for that person. Probably the easiest thing we can be doing in this space. Because again, this still requires patients to fill out forms. Again, 17% of Canadians have, 83% haven't. Whether or not that's going to get any better, this would certainly not fix it. It's not an entire fix. We would also potentially need to explicitly acknowledge in any substituted judgment conversation or any best interest conversation that the person no longer able to make decisions likely cares about the people around them. And that taking care of those people is probably, or should be presumed to be, something that that person cared about. And a part of their values and goals that we use to evaluate treatment options. So that's one option. That's one path. That's if we just want to stay with the system of patient instructions, substituted judgment, and best interest, and not touch that. I have a number of folks who have told me that they think moving any of those standards would be a terrible idea. So I'm trying to find ways to work within that reluctance and within that resistance. If, however, we're willing to be a bit more creative and imaginative, we can start to move away from this language of patient autonomy because it is misunderstood and misapplied in many, many contexts, and instead move towards a respect for all persons. And in that, explicitly acknowledge that the non-professional people around patients are persons to be respected. That may also be an easy way to go. That takes a tremendous amount of education. Possible, does not require any legislation, does not require any regulation, doesn't require a whole lot of professional movement, but it might start moving things in the right direction. To do this, though, we may start to have to identify and articulate ethical standards for informal caregivers, so that it is more of a specific something that we can evaluate, that we can recognize is morally relevant, is ethically important. Or we could potentially change the legal standards specifically for non-professional surrogate or substitute decision makers. It's a huge lift, that one is. So this is where I'm looking, because this is what I can do. And so here's the really absolutely definitely can push back. I've identified at this point roughly sort of 4 broad duties that caregiving decision makers frequently take on, but not always. And so let me be clear that this is trying to recognize what's already happening and not necessarily prescribing what needs to happen for any caregiver or any decision maker. And so this is very flexible and fluid at this point. But my sense is that the vast majority of substitute decision makers especially those who are responsible for the informal care for this person, take on a duty of support. I feel like they take on a duty of advocacy. Sometimes they're even called patient advocates. They take on a duty of loyalty. They take on a duty of legacy. Let me explain a little bit more what I mean by each of these. So for support, this is the transportation and the errands. We need to acknowledge that that's real and important and worth factoring into decisions. Similarly, for food, shelter, clothing, and hygiene for these folks, companionship for these folks. This is real. This is real time. This is real money. It should be acknowledged. The duty of advocacy may land more heavily in an especially fragmented and under-resourced healthcare system. The fragmented part, I have a hunch, is probably more of a US thing than Canada thing, but I'm getting the impression that that's probably a somewhat shared characteristic of both of our healthcare systems. So to the extent that people easily fall through cracks, especially in transfer from one institution to another institution, from one care setting to another care setting, or even from one specialty to another specialty, or even one shift to another shift, the need to continue to speak for the person not able to speak for themselves is frequently something that these decision makers take on. Additionally, this may be especially tangible for folks who come from communities that are historically and currently underrepresented in our healthcare professions, for folks whose beliefs and values are underrepresented in our professionals. So especially where patients and their substitute decision makers are not seeing themselves reflected in the team caring for them. This need to advocate or fight may be a source of pride, as well as a responsibility that they take on. For loyalty, this is acknowledging that substitute decision makers also maintain ties, often, again, not always, to a larger community for the decision maker's support. So just as none of these patients are able to make decisions for themselves, they need to be supported and they have someone, our substitute decision makers need support. No one person can take care of two people all by themselves. It's incredibly difficult. Burnout is common. And so to the extent that our substitute decision makers are relying on extended family to help with care, are relying upon a faith community, a neighborhood, an ethnic community, those substitute decision makers have obligations or responsibilities or expectations to that community that may sometimes be implicated by the decisions that they need to make. I feel like we need to recognize that. And then lastly, when many folks have capacity, they make decisions in terms of, how will I be remembered for this? And sometimes families have a sense, or ethnic communities, nationalities, tribes have a sense of, what does it mean to be a blank? If I do this, what does it mean for how people will see, pick your group, to be a Herbst moving forward, to be an American moving forward? What will my decision in this space mean if I feel like I need to be representative for a larger community? The substitute decision maker may be very invested in that reputation. Maybe similar to the patient themselves, and maybe not. But recognizing that many of us, when we get to make decisions for ourselves, factor that in. Why shouldn't substitute decision makers be able to factor that in where they are part of that reputation, where they are part of that legacy, where they are part of that? Now, that part's radical. I get that. And part of the reason why we have a clean line right now is because all of these can be corrupted. People have fears. People in this space especially have fears. Support can turn into control. And a loss of control is one thing that many, if not most of us, are afraid of in some capacity. Some people more than others. And so being able to be the one who is deciding everything about this for someone else can actually be an attempt to simply make certainty out of uncertainty in the context of health and poorer health and disease and illness. Advocacy, I think, comes out of a fear of harm. And you can start to get so blinded to that fear of harm that you can no longer necessarily process a lot of the information that's coming at you. Loyalty, I think, comes out of a fear of being alone. And so for a substitute decision maker, the idea that they would make a decision that would leave them on the outs, especially for someone who may be dying soon, it means that they grieve alone rather than in community. And that can be terrifying. And lastly, this legacy, this idea, this fear of being dishonored, or a fear of being misremembered, or a fear of being rewritten. So to the extent that any sense of who we are is how people perceive us, and what people will say about us when we're gone, our substitute decision makers have that too. And the decisions that they're making may implicate that for others. And so recognizing those, this is, again, a very early thought of what we might do about this, how we balance these, how we factor them in. Not sure yet, but this is part of the how of possibly creating new ethical framework for, or a new standard of care for informal care decision makers. So again, these are the two questions. I let Jen know that these were two of the questions that I was going to land on at the end, so I will now turn it over to Jen Chandler.
I think this idea of trying to get more clarity on what the standard sort of care, as it were, the expectations of informal caregivers is extremely valuable idea. I mean, we do have criminal negligence and the requirement to provide the necessities of care if you're in a caregiving role for somebody who's dependent, but that's a pretty extreme deviation from what might be expected, and that leaves an awful lot of territory where something could usefully be said. And I think there's also a lot of value to being more explicit about the expectations, because it strengthens the claims for broader social support for caregivers. If we say, hey, these are all the things we're expecting of this group of people, how about we take seriously the burdens that they face as well? So thank you very much for the set of ideas. I think it's a very valuable way to think about this, and also to put a bit of a spotlight on a community that is a bit of an afterthought, really, and is yet so fundamental to the success of the whole healthcare system, really. It's the actual healthcare provided is kind of the tip of the iceberg for all these chronic conditions in terms of healthcare. So I thought what I would do is be a little bit quick here with just throwing out a couple of ideas that are meant to be kind of provocative critique, just by way of thinking and probing sort of the boundaries of this idea. And so I'll pose them and leave them with a little bit of a question that you can pick up or not in the discussion, but I also want to leave space for all of you to raise some questions. So I guess the first observation I'd make is I understand what you are saying here as a little bit of a pushback against the idea that it is a conflict of interest for a caregiver to incorporate their own needs, interests, and capacities within the decision that they're making for another. And in fact, realistically, the best interests, one might say, of someone who's dependent include the health and well-being of their primary caregiver. So this makes quite a lot of sense. However, I wonder if there are some circumstances that are just too dangerous for one reason or another, where we would not want to compromise. I want to think of whether there's a spectrum of situations where the risk of conflict of interest for one reason or another becomes so acute that we want the bright line firm rule. And I started thinking about that a little bit, and there's a range of circumstances where we actually prohibit substitute decision making altogether, primarily because of the risk of conflict of interest and of wrong decisions being made, but also because of perhaps the extremeness of the treatment. So let me give you just a quick catalog of what I could think of. So if we look at our Mental Health Act, what has been called psychosurgery is now called neurosurgery for psychiatric disorders, which many people don't realize continues on in many different forms today, not the old Freeman lobotomy of the 20th century. But the rule is, in order to have that treatment, which any capable person can have if they want, you have to give first-person consent. And this essentially forecloses people who are incapable from getting it. Substitute decision making is utterly off the table here. Secondly, medical aid in dying. We know if you're incapable, there's no such thing in Canada as substitute consent for medical aid in dying. We have the Eve case from the Supreme Court, which basically says no contraceptive sterilization for an incapable dependent. And that, if one reads the case, is all about the concern that the decision is being made for the benefit of the substitute decision maker. It was the mother of Eve who was worried about her daughter becoming pregnant, and then the mother having to bring up this child. So here's a clear example of a decision, a court saying you don't get to incorporate your own interests, caregiver. You're saying you're elderly lady with limited resources, but you don't get to prioritize, as it were, your own interests in this context. Now, this is against a background of eugenic sterilization of people with mental health disabilities and so forth. So it's within that context of a fear of that conflict of interest and an abusive application of the caregiver's interests above that of the individual. And then live organ donation. We also don't permit someone to consent on behalf of an incapable, whether a child or adult, to donate to a family member. Again, an instance where if one prioritized or took a more communal understanding of the benefits of the whole unit, we might be a bit more flexible on that. Maybe it is in your interest to save your sister. So notwithstanding that, so we can look at these, in all circumstances there, we have said there shall be no consideration of the interests beyond the patient. And we're so concerned about conflict of interest, we're not actually even going to permit SDM to make those decisions. So I've called this the nuclear option of protection of people with disability, because in the instance where it forecloses access to valuable opportunities or treatments, or even possibilities of legacy, like saving a sibling, that are very valuable to people who are capable, and they get to do that, we've said, actually, no, we're so worried about you, we're not even going to let you have access to those possibilities. So in a way, it's a restriction of choice for a group of people to protect, but it's a restriction of choice. So I wonder if one can look at those and make some conclusions about situations where, actually, you know what, we do not want to admit the broader circle's interests into decision making.